Good evening, everyone. I'm Anne-Marie Pasco, Director of the Radiology Leadership Institute, and I'm very pleased to welcome you to the second in a quarterly series of Imaging 3.0 webinars sponsored by the RLI. These webinars will be moderated by a member of the ACR Imaging 3.0 workgroup and will feature a series of real-world case studies from fellow radiologists that will arm you with an action plan that allows radiologists to take a leadership role in shaping America's future healthcare system. Tonight's session is based on the Value of Hard Work case study, which features Dr. Samir Patel, Director of the Value Management Program at Radiology, Inc. Dr. Patel is also joined by Ray Kendall, Executive Director of Radiology at Elkhart General Hospital. We are very fortunate tonight to also have Dr. Giles Boland for our moderator. He is Vice Chair of the Department of Radiology and Physician Director of Network Development and Referral Management at Massachusetts General Hospital, as well as Professor of Radiology at Harvard Medical School. Dr. Boland believes that radiologists must take the lead in transition from volume to value-based paradigm, and tonight's case study is an excellent example of that. By participating in tonight's presentation, you will have the opportunity to earn one Level 3 mandatory RLI credit. You will receive an email tomorrow with instructions on claiming this credit and an email in a day or two with a link to tonight's recorded session. Before I turn it over to Dr. Boland to get things started, I wanted to quickly review two housekeeping items. Tonight's presentation is scheduled to last about 35 minutes and will be followed by a 25-minute Q&A. Hopefully you've already had an opportunity to read the Value of Hard Work case study and submit questions for tonight's panelists. If not, please feel free to submit questions at any point during tonight's session by typing them into the questions pane. Your questions will be addressed at the end of the presentation. And finally, if you have any questions now or at any time during the session or experience any access issues, please feel free to type your question into the questions pane as well, and someone will assist. Again, thank you so much for your time and interest in this exciting series. And I'd now like to turn it over to Dr. Giles Boland to get the discussion started.
Thank you, Anne-Marie, and good evening to everyone wherever you are, some on the East Coast where it's 8 in the evening, and hopefully some on the West Coast where it's late afternoon. We hope that this will be a very fruitful and productive hour for you, and that we can all learn together about how we can address our future in the volume to value paradigm. So I'm Giles Boland, as mentioned. I would like to also just briefly, again, Samir Patel and Ray Kendall. I should also point out it's a very timely example of what we are doing as a profession, how it can lead to leadership positions in this new healthcare framework. Samir Patel has just been, literally half an hour ago, voted to be on the board of his hospital, which I think is a great achievement and really reflects the hard work that he's been doing around what he will present tonight. So already on that front alone, we have tangible benefits. Here are disclosures, and I'm going to move on to the beginning of the presentation. I'm just going to give a little 5-minute intro or so, and before handing over to Samir to present the bulk of this presentation. And I want to just give you my idea of 5 themes which is going on in healthcare right now, and 5 healthcare drivers, much of which you'll know already, but I think it just frames what we're going to talk about and why Imaging 3.0 will be crucial and critical for radiologists to address these drivers. So first one, no surprises, Obamacare, healthcare reform, a big major game changer in how we are required to think and practice medicine. Another one, which really comes from a different angle, is precision or personalized medicine. And in some ways is very much a challenge, if you will, against Obamacare, because much of personalized precision medicine actually is going to cost a lot of money, particularly already in your organizations, around very expensive chemotherapeutic drugs targeted at specific genetic mutations from patients. But also personalized medicine from a patient point of view as well. The third driver, as far as I can see, is what I call participatory medicine, in that through care redesign, we're going to have to rethink how we work with our fellow physicians, nurses, social workers, psychologists, etc. We're going to fundamentally redesign the care pathways around disease pathways, so-called integrated practice units, which was well written up by Michael Porter, etc. And it's not just participatory with other physicians and other healthcare workers. It's participatory with patients as well. As we're all familiar, they are taking an increasing role in their care and advocating for their care, and we'll need to talk the language of patients, not just to ourselves amongst healthcare providers. The fourth theme that I think is, if we get all these right, that organizations who do this well will be able to create new markets and brand themselves to take advantage of healthcare reform, particularly around population health management. Sort of one of the fifth driver, which to me is that IT intelligence is going to really hold all of this together. It's absolutely crucial that we have sophisticated IT tools that will help drive performance, enable us to monitor it, to data mine, and in fact, of course, with big data to be able to look at trends amongst patients. Ultimately, this is all driven to the new paradigm of value and outcomes in healthcare reform. So that's the background. So moving on, what are we going to talk about tonight? A fundamental part of what we're talking about is Imaging 3.0, and I will briefly say what it is and why it matters. And then we're going to hand it over to Samir, who's done really a striking example of how the certain components of 3.0 can add tangible benefits in his organizations, but mainly and particularly to patient care. And then we're going to look at how you can make Imaging 3.0 work in your practice, and certainly we'll have some questions around that. So 3.0, for those of you who are not yet familiar with it, is a vision and a game plan for us as radiologists and radiology departments for providing optimal care. And I shall read just briefly from the ACR's Imaging 3.0 call to action, and it says this: it's a call to action to all radiologists to assume a leadership role in shaping America's future healthcare system. The campaign's goal is for radiologists to move beyond being simple image interpreters to becoming integrated leaders in the new and evolving healthcare environment. Its thrust is for radiologists to deliver enhanced value to patients through 5 key pillars: imaging appropriateness, quality, safety, efficiency, and satisfaction. Patient satisfaction. For this to succeed, radiologists must be primary drivers rather than followers of the change processes necessary to achieve the vision of 3.0. And I think tonight you're going to hear a stunning example of that with Samir's presentation. So these are the tenets, if you will, of the 3.0 volume to value-based transition. We're going to be value-based, moving from a transactional to a consultative-based practice, moving to a patient-centered practice. As Jim Rawson said, he quipped, it's hard to put the patient at the center of the room when we're sitting there ourselves. So we have to get out of there and put the patient at the center. Moving to outcomes focused, rather than being commoditized, we are integral to the whole practice and care within our organizations, and be accountable rather than invisible. One thing I just want to briefly end up with is to conceptualize how would we address 3.0 in our organization. And put up on the website here after this presentation, I and Richard Duzak have written a radiology value chain series in the JACR, which is currently running, which talks about a lot of what we're talking about tonight and how we can address it and the tools needed to deliver it. But essentially a simplistic radiology value chain starts with scheduling through protocoling, proceduring, reporting, and distribution. Ultimately, our main product is to deliver an actionable report. And if you ask us what business we're in, and Dieter Ensman takes the credit for this from UCLA, frankly, this is what business we're in. We're in the information business. We're there to deliver succinct, structured reports which incorporates all the relevant biomarker data, which is now becoming available on electronic medical records. We can use it for data mining purposes. So the information business is critical and key to what we are to deliver to our stakeholders. Ultimately, because actionable reports, those that referring physicians and to some extent patients can then proceed to the next relevant therapeutic diagnostic step, will affect outcomes. So that may be of help to you, and further reading after today's session can be performed with the Value Chain series in the JACR. So 3.0, it's, in summary, 3 key actions. Frankly, it's a culture change. I would go further than that and say it's a mindset change. to really grasp this seriously, we have to move from a transactional fee-for-service system to one that is essentially value-based, and that is fundamentally a mindset and therefore culture change. Certainly it's going to need multiple tools, and Imaging 3.0 already has delivered a number of tools, and some of which Samir may talk about this evening, an alignment of incentives between the different stakeholders. So at this point, I would like to hand over to Samir for him to share what he has done in his organization to address some of these aspects of 3.0 and how relevant it is today, and the fact that he's taken this leadership position, he's able to transform his organization and radiology into a highly relevant, visible practice. So Samir, over to you.
Great. Thank you, Dr. Boland. Thank you, Anne-Marie, and members of the ACR that has given me the great opportunity to share a story that actually was brought out by many of the work that many members of the ACR, including Dr. Boland, have done. I will share no magic recipe and no magic secret is basically many of the tools that the ACR has provided me as a practicing radiologist to be able to share how we've implemented that to the benefit of not only the group I work for, but also the hospital and the patients of the community. A little bit about the group. My group is private practice. It has 28 radiologists. We've been in serving North Central Indiana since 1904, and we cover 3 hospitals, and I'm primarily at Elkhart General Hospital, which is a 365-bed hospital. So one would surmise that my practice possibly what could be represented as an average practice across the country from a hospital size standpoint. One of the things is being around so long, primary metrics as prior to the development of Imaging 3.0 did include things such as primary volume metrics. How many studies does one read? How many exams does a practice produce? How many CAT scans are done? How many MRIs? Traditional volume-based metrics. But obviously in the past several years, it has become clear that it's no longer going to be enough just to be in a reading room and just read films and expect that things will continue the great degree of success we had up until about 2007. We saw this locally. One of our largest hospitals challenged us as recent as a couple years ago, and we're actually receiving feedback from members of the medical staff that the radiologists, maybe we need to go in a different direction as far as the radiology group is concerned. And this is highlighted in the Imaging 3.0 case study on the ACR website. The actual, to hear it straight from one of the presidents of the hospitals gives that perspective. So something really needed to change. And I will disclose that my first role, leadership role, was chairman of the Elkhart General Hospital in 2012 and 2013. And prior to that, I'd done some work with my group internally, but never really had a large leadership position. So kind of what got me to develop this program was not only the timing of things, but also there was a lot of activities that myself and many other colleagues in my group were doing without necessarily being recognized in the traditional volume metrics. Spending time on committees, going to conferences, doing QA report. There was never really a great forum for that. And so one of the things that we did was we tried to tie some of these activities, which many were already doing, but we really tied it to medical directorship, fees, and justification, and really started to now show our hospitals all the things that we were doing. And let's see, we'll go to the next slide here. So we started out, and this is really simplistic. Most of the radiologist activity still occurs in the reading room. So we developed basically papers for all the reading rooms at all the sites that we covered. And we started this program in 2012 at Elkhart General Hospital and extended it to our other 2 hospitals in 2013. We basically have forms of paper, as you can see, and a radiologist would put their name, the date of an activity, such as going to a conference, going to a meeting, going to a committee, the hours spent on the activity, and a brief description of that activity. This is basically how we started in order to get buy-in from a lot of the radiologists, something very simplistic. However, now, because there's been tremendous buy-in, Some of the radiologists actually fill out these sorts of forms online. We just have a Microsoft Excel spreadsheet, and we are in the process of developing a smartphone app for physicians to directly enter various value-added activities. But this is how we started, just a piece of paper. So what happens when we fill out those activities? They go to a centralized location in our radiology practice. We have our own billing office. We have a value management program executive coordinator that collects all the previous sheets of paper on a monthly basis and logs them into a Microsoft Excel spreadsheet with these categories. Again, anybody can do this. It's very simple. And after a month, all the activities are logged and collated, and we have it separated out by location, activity, physicians. And then when we start to sum this up over the course of a year, it becomes very powerful data, which I'll have the pleasure of showing. So our first year of system-wide implementation was 2013 across all of our 3 hospital sites, and we do cover several outpatient imaging centers. So True North categories, I also have a background, black belt certification in lean healthcare, and this is based off the Toyota model, and Toyota talks about True North categories in the way that how it measured its business. It was based on driving an organization to succeed in the long term, combating complacency, and keep the organizations continuously focusing on improvement, necessitating participation by everyone. And you can start to see that there's already a lot of overlap between these categories and the categories, the pillars of Imaging 3.0. So, and we'll dive deep into this, but our group was able to quantify over 9,900 hours of value-added activities, and I'll share some of the breakdown and how we actually categorize some of those activities. So these are all the hours that we as our group, our 28 members, who are spending in various different formats and venues that were not being compensated on a traditional work-RVU basis. And chances are, this is probably how many of your groups are also functioning too. So what categories are available? So this is generated the value-added matrix with the 4 pillars from Lean Enterprise, which carbon copies very well to Imaging 3.0, and the value chain for everything. So it's no longer just interpreting studies. We are actually doing all these particular different activities. As far as where the categories came up, most of these categories came from the literature produced by the ACR, Imaging 3.0, previous publications, and the radiology literature. The good thing is many of these same areas of activity or non-wRVU related functions are very similar to hospital goals too, as far as being involved with that. We will not have time to go into all these individual details, but this provides a platform from which value-added activities are categorized, and it serves as a template for defining investments and outcomes from where for a particular practice to start showcasing it to their particular clients and physicians, everything that they do. This also very well parallels what is required of medical directorship from the MGMA data, and so incorporated are those categories. So this is not meant to be an all-inclusive list. It's not meant to be a static list, and things will change in the future, that's for sure. But we really feel that these 35, 36 categories are what should be important to hospital clients, and how can we optimize this in a collaborative fashion. So if we look at the individual categories, as I mentioned, we did over 9,900 hours. This is basically the categorization across all of our entire group into each of those buckets of category. And their hours is on the y-axis, and each major category is on the x-axis. Details of this I have submitted an article to Journal of the American College of Radiology, sort of diving deeper into the program, and this presentation and some of this data review is a snapshot summary of that. Not exactly sure when it will be published, but it has been accepted for publication by Journal of the American College of Radiology. Several categories to note. You'll notice there's a heavy emphasis on customer experience, and we define that in several different ways, but there are various different group activities such as sedation monitoring of patients, talking to patients about their breast ultrasound results, and other activities where it really requires focusing on patients themselves. Community service is a huge bucket, and the way that we came up with 1,866 hours is as our group has a private foundation. We donate monies to local charities on an annual basis, and we've been doing that for over 25 years. What we did was the amount of money that we donated, divided it by the average hourly volunteer rate in America, and then we came up with this figure. So this is essentially the hours equivalent of how much money we donate to the community on an annual basis, and we support local charities throughout the regions that we cover. As far as national and state radiology, this is where it really is important, and I would strongly urge all members to participate in the ACR because, again, I did not develop many of these things on my own. And in fact, I owe a great deal of gratitude to the ACR for giving me all these tools and ideas in order to implement these. And I'll tell you that our C-suite administration really feels honored in a private practice setting in a medium-sized hospital when one of their staff members participates in national activities such as this, national committees. It is a tremendous source of pride, and it does invoke a tremendous amount of respect for the individual, because these are not easy things that all members of the medical staff and all people outside of radiology come to pretty easily. So that is my plug for everyone on the call, that being on a committee for the ACR, supporting the ACR, can really help make a benefit in your local medical environment. And transcription I've included on there. We found a way to sort of calculate how many hours of transcription time we have reduced. So now if we go to, and actually before we go to that, I have the privilege of having the executive director of radiology at Elkhart General Hospital, where I primarily am at, Ray Kindle. And Ray has seen the transition of imaging. He has a great deal of experience, and he's seen the transition from imaging 1.0 to imaging 3.0. So, so Ray, if you wouldn't mind giving your perspective, sort of the first time I presented this data to you, and the information in this format, what did you think?
Well, first of all, I'd like to say thank you for letting me participate. I feel honored that I'm the only non-radiologist participating on the call this evening, so thank you all for that. And so, as you have alluded to, I've directly observed the commoditization of radiology with the advent of digital imaging. Gone are the days of referring physicians coming in droves to the radiology department and crowding around view boxes in the reading rooms. We were warned of this about 13 years ago when we used the Georgetown model to develop our PACS here. And you know, they indicated there that, you know, when you have ubiquitous availability of the original quality images everywhere, you know, the collaboration between referring physician and the radiologist will be lost, and I've seen it. So with this document, I saw enhanced and perceived actual value that the radiologists provide to referring physicians. Quantifiable metrics measure time and output. Numbers quickly turn opinion into fact. With that, visual management is one of the pillars of lean thinking. So I see this as a very powerful tool.
Great, thanks, Ray. As we go on to sort of driving down a little bit more deeper, so this is a bar graph, and basically, again, I mentioned our group has 20 radiologists, so each of the bars represents an individual radiologist in the group. And the green component of the bars is basically traditional wRVU units, and that's just based on straight up from our billing office. Now the pink is what we had defined was on the previous slides, when individual radiologists submit particular activities, we know how many hours over a particular time period, and in this case 2013, how much individual radiologists submitted as far as the hours of value added, which we defined earlier. And we converted that number into what's called the value-added unit, or VAU. And in order to kind of equate things, the number of hours a radiologist spends on value-added activities, we multiply that times the average wRVU generated per hour of work in our practice, and then those are the pink bars. So when you add the pink bars to the green bars, that's what we define, and in my paper that I published, total radiologist productivity. So not surprisingly, most of the work that is done is still wRVU related, but we understand now if you look on everybody's bar, everybody has some degree of pink, and that's the buy-in. Every radiologist is doing some form of value-added work, and as far as our total radiologist productivity, approximately 15% of the total radiologist productivity is spent on non-wRVU related activities. So this is a big tool, and prior to 2013, we never had this data. It was basically the green without the pink bars, and you can see for some radiologists that invest a lot of time into value-added activities for the benefit of the group, it markedly changes their total productivity. It also speaks to the deep bench strength that one of my colleagues and current chair of the Department of Radiology at Elkhart states is we have it's not just a single individual doing all the work. There's been involvement and buy-in by everyone. And so that to me speaks to the culture that everyone is now getting involved. And if this was extrapolated to the entire field of radiology, in the paper I estimate that that would be over 10 million hours of value-added service performed by radiologists in this country. And if you assume an average economic value of $250 per hour, that would translate into an economic value of over $2 billion. So this is basically the time investment, and when this is presented to hospital C-suite members, they can see that a significant amount of time and effort is invested by the radiology group for the benefit of the corporation and benefit of the hospital. However, this is just the investment part. So what is the return? And so that is a key point, and I apologize that this is this slide has turned out sort of small, but this slide is essentially as a template of outcomes, and under each category that each individual location, each practice, whether it's private practice, academic practice, employed, non-employed, this is basically a scorecard of outcomes that can be listed by the radiology group and presented to their administration to showcase all the outcomes that have been performed. And again, I would like to chime in, Ray, here, if you could speak, Ray, if you wouldn't mind speaking to the outcomes and how tangible this is and how relevant a document like this is for you in the hospital.
Sure. Well, first of all, the slide is small, but it represents a template that is totally configurable by each entity. So you can populate this with whatever activities you choose to use, and it's a totally collaborative effort, you know, to combine administrative technologists and radiologists. It will polarize the radiologists, administrators, staff, and technologists with a sense of pride in doing the right thing. One example that comes to mind is a recent CT purchase that we just went through, and so Elkhart General has earned a Low-Dose Center of Excellence Award for the dose reduction efforts we've done in CT. So with the idea of furthering this goal, a decision was made using facts and data to purchase 4 scanners for 2 hospitals, despite the fact that the other hospital historically had purchased another vendor's equipment predominantly. So we're now well positioned to become the Low-Dose Center of Excellence for the region. Another distinction made from this work is that we have become an accredited facility for our lung cancer screening program.
So thank you, Ray. So this is really as a scorecard and a sheet that, again, is presented to the hospital, but almost actually performed in conjunction with the hospital. So, so individuals such as Ray and his team and senior management, that we basically list for all the effort that we put in, that this is what the hospital is getting that is not easily replaceable. And so if a hospital was looking to replace its radiology group, not only do you need somebody to interpret the films and everything, those sorts of traditional radiology efforts, but all these activities, all these efforts, this other investment would need to be matched if the same level of care is to be provided. So if we go now to the summary, some additional numbers related to our program. So these are, again, items of involvement that our private practice group has done in 2013 under the individual different buckets. And when this is presented to the hospitals, and this is not just from one side, so under the quality bar, we'll just go over a couple real quick. our group has been involved in 104 national accreditations and designations related to imaging. The vast majority, over 95%, are related are ACR programs. So we can pull from experience in looking at the image quality, going through the accreditation processes. It's the benefit not only to the hospitals where we're doing it at, but the benefit that we maybe learn at one hospital, we can share it across the enterprise to other hospitals. We do participate in PQRS initiatives, and there was a great paper by Rich Duzak several years ago that showed at that particular time only a very minority number of radiologists were actually successfully participating in PQRS, understanding that it becomes a penalty, financial penalty, really quick. When we look at conference participation, and when I ask some of my colleagues, how much time do you think we spend in conferences on an average year? And when I tell them that it was close to over 630 hours, it is almost mind-boggling. But we share the experience from a multidisciplinary interaction with other specialties, with non-physician staff. That's benefit to the group. I've also put in some other items there under service, and then also there's some other items there under utilization management and professional development. So these are, again, some other outcome things. A couple items under the professional development is under, we do, even though we're primarily private practice, we have engaged in a significant amount of research, and we do spend a significant amount of time on teaching. We do not have a residency program, but we do support local medical students, individuals from other specialties in teaching and educating them about radiology as far as clinical decision support, utilization. And our practice has published 5 peer-reviewed articles. So even in a private practice setting, and it's not as if everybody needs to do all these activities, but somebody in each individual person in the group can find some activity in order to do. And again, some other outcomes, and these are just straight examples of things that we found important that maybe other groups can look at or pick other projects. But this goes into, on the outcome side, we spend time looking at CT for pulmonary embolism. We looked at inpatient MRIs. We looked at ED CTs. And before, it was purely, okay, how many CTs for PE did we do? How many MRs did we do? How many CTs did we do from the emergency room? But now we're actually more looking at outcomes. What percentage of these studies are positive? What percentage of these studies are appropriate? And so these are going to be the new metrics, and we are starting to track these, and we have showcased these because there was a general perception that we were ordering too many studies for certain indications. But then when we showed that a significant number of these studies were having significant pathology related to the patient's acute event, it really shed a new light. And previously, we never had this data. And we've shared this with multiple committees in the hospital, including the quality QI committee. We've shared it with senior hospital administration. We've shared it with other departments, such as the ED, the hospitalists. And this really bears out with regards to what outcomes we're now looking at. As I mentioned, my background is in lean healthcare most recently, and the hospital is very ingrained here at Elkhart General Hospital in lean. The beauty of this, implementing many of the things of Imaging 3.0 and many of the things that ACR has proposed, not only can result in appropriate profit enhancement through a combination of revenue enhancement as well as cost savings. And so this is another way that we can showcase that in this new paradigm, not everything just needs to be based on volume. And there are opportunities for profit enhancement. And again, I'll ask Ray to chime in. The first time I showed him these numbers and said, this is what we're doing. We're doing things the right way. And oh, by the way, there's a benefit to the hospital and the health system. So Ray, if you wanted to make several comments about this.
Absolutely. This is a very powerful slide, as you may agree. And as you read down the list, you'll quickly see emerging the 5 pillars of Imaging 3.0. Quality, service, appropriateness, efficiency, safety are all evident here. Not all value-add dollars and cents add up to dollars and cents, however, but the dollars and cents will quickly grab the attention of the CFO and the CEO very, very quickly. The The first item on the list does both. The reduction of contrast in the ED yields appropriateness for the correct contrast, which many times is IV, yielding higher reimbursement. Secondly, it shaves off at least an hour of patient wait time, yielding greater patient satisfaction. It also allows the ED staff to turn a bed faster, yielding efficiency. In this particular hospital, we have the third busiest emergency department in the state of Indiana. Other examples are carotid CTA and contrast-enhanced CT chest, abdomen, and pelvis with standardized structured reporting. As you know, CMS radiology reports require the quantity and type of contrast evident in the report. As the radiologist forgets to indicate them, then the exam must be downcoded to without contrast at lower reimbursement. CTAs also require a statement of post-processing. With the use of our PowerScribe 360 and structured reporting, the technologist enters that data as they're doing the exam, so it's never forgotten. This collaborative effort continues down the list, the last item regarding MRI sedation. Dramatic reduction in the type and amount of conscious sedation used by MRI was realized here by including the radiologist in participation in architectural layout and design of our new wide-bore MRI to include patient selectable lighting, music, and ceiling art. The savings listed was predicted at the onset and at the time we purchased this equipment and verified 1 year post-install. Data like this is very useful in internal capital budget negotiations. You know, resources are scarce these days and spread very thin, so the return on investment is a very powerful tool, and the data on this report really adds credence to your case as you defend it against other offerings within the facility.
Great, thanks, Ray. The key crux for this, from my perspective, is I always started out with the ACR appropriateness criteria, practice guidelines, and standards whenever a process improvement was to be started. And then, so that was always the initial, is what is the right thing to do? And that was, and then also expert consensus documents, but really the crux of this was really the ACR appropriateness criteria, practice guidelines, and standards. So if this was the benefit to the hospital, the natural question is what are there any potential benefits for individual radiology groups to enhance their non-RVU income, because the work RVU income is continuing to go down. And this is just a short template of areas for groups to consider optimizing. Our group has activities involved in many of these areas. We do receive medical directorship fees, but in order to justify those fees, we present all the activities that I mentioned before at each of our locations. As far as quality incentives, there's certain client base, so we have certain contracts with the hospitals where we say if we meet these sort of metrics, there will be incentives, so we have some of those in place. We do participate in national quality incentives, PQRS, CMS, maintenance of certification. An interesting thing we found out is through the performance of CME, and we have a critical test result software management system, we've actually reduced our premiums on malpractice. We use a commercially available critical test result management system, and when we took it to our private malpractice insurance carrier, they gave us a reduction on our malpractice premium because of failure to communicate is such a huge item for medical malpractice. Imaging interpretation, we do participate in some research studies. We do overread certain exams that the hospital bills and pays us on a per-click basis. We do have some call stipends, and we also have administrative. Those are other avenues for other groups to consider. Doing various consulting, informatics services, speaking fees. So this is sort of the new template for potentially to maybe bridge some of the lost revenue from traditional work RVU, what has worked in the past. So, so kind of in summary, what prompted the change was really the marketplace. The hospitals wanted, you know, more value and not so much focusing on volume. And that's really what changed actually within the last 3 years. As far as the obstacles, one of those things was, again, we tried to keep it very simple. We asked the radiologist if this is how it would work, and so we started out on paper, but we're rapidly looking to move to electronic and moving to a smartphone app. And then as far as incentives, the last slide I mentioned, we have been able to translate it into the value-added matrix categories in this into real dollars for the group as well as for our clients, the hospitals, because if our hospitals do well, we will do well. And it truly is a partnership, and I'm very fortunate to work with Ray, and many of these things we've worked together on. We've done this together, and we've really matriculated the Imaging 3.0 culture from myself when I was chair of the department, Ray as executive director, all the way down to the technologists. And so that is basically our story. There's no magic formula. We just basically took all the things that the ACR and work that Dr. Boland has done and other members of the ACR that have given us the chance to implement these in private practice. So thank you, Dr. Boland.
Thanks, Dr. Patel. Thanks so much to you and to Ray for this presentation. Could you just advance one slide, please? Because we're going to, over the next, we've got about just over 15 minutes left, so hopefully we can get through as many questions as you can. As was said by Anne-Marie at the beginning of the webinar, you are able to ask questions if you put them into the question pane in the control panel. I see a few questions already, and we'll hopefully get through as many as we can. Some people actually had asked some questions and sent them in before the presentation today, and I actually have 3 of those which are really directed to you, Samir and Ray, and I'm going to read them out in turn. The first one is, was the radiology value-added matrix developed with input from hospital leadership significantly, or is it primarily driven by you? And I think you've partially answered that in your presentation, but how much input and advice did you get from hospital leadership on this?
So I did generate it originally myself based on reviewing the literature, various presentations, and work the ACR has performed. However, again, it's not meant to be a static document. So in fact, when I started this in 2012, I originally just started it myself, but then the format that I just presented, the value-added matrix, is the most current version, and there were some modifications after talking with Ray and talking to senior hospital leadership. So I think it serves as a starting point, but by no means is it meant to be performed in a vacuum. And then it was also a way for me to educate the hospital administrators that these are the things that should be important to you. But it was collaborative, but originally I did develop it originally myself, but future modifications do require collaboration.
Okay, thanks. The next question, actually, I can see various people are sort of asking around about the same question. Before you answer it, the first question here is what additional resources were used to develop the radiology value-added matrix? But others are asking along similar lines, what tools do you use to measure the rates of various quality metrics and outcomes that you defined? For the outcomes measure that you described, do you use an automated tool to determine the positive cases for PE, acute significant findings, etc.? Slightly different questions, but tools are resources. So what additional resources do you use to develop it, and what tools are you using to measure it?
Okay, so several items as far as how many hours of teaching, how many hours of conference, and some of those metrics were gleaned just directly out of the input database. So that was that. The other things as far as for PE, the PE data, inpatient MRI data, and ED data were actually specific individual projects during certain time points. However, we are looking into a data mining solution. The hospital is looking into a commercially available data mining solution. So we will not only be able to get this information just at one snapshot of a period of time by pulling the cases and actually looking at the reports, but actually utilizing a data analytics program to track not only this project, but other projects going forward. And there are several that are commercially available. And so most of the major speech recognition and other corporations have those data mining programs.
Thanks. And Ray, obviously feel free to chime in. The next question, and Ray, you may want to participate in this one too, but I'll direct it initially at Samir. Now that the value-added matrix has become part of the culture at your hospitals, have you noticed any negative effects For example, at the end of each year, if the established metrics are not similar to the previous years, are the hospital leaders now asking for an explanation?
So I'll at least start this out, and I will first say that 2013 was our first year of doing this system-wide. So we are actually just now in year 2, and so we'll wait and see what the year 2 data shows compared to year 1. Preliminary data shows that we're actually capturing more value, and we actually have had a greater degree of buy-in. However, we just have not completed year 2 yet. As far as any negative effects, I think what we did is we share those internal individual radiologist numbers individually, privately within our own group, and everybody can kind of see who is doing what, and more importantly, who is not doing much. And so there is a degree of peer pressure related to that. And as far as on the hospital side, I'll let Ray chime in, but you know, we're just still at the beginning of this journey, but I'll let Ray chime in his thoughts.
Well, I like this part of it because I remember a meeting when Samir presented the first year's results. I think there's 105 value-added activities that occurred that year, and the CEO of Beacon, which is the parent organization of both Memorial Hospital and Elkhart, said, well, there's too many metrics on it. How can you keep track of all of them? And Samir laughed. He said, well, I got 145 going so far this year. So it grows. And so the beauty of it is you know, you monitor and you slice and dice and present the data at whatever needs and needs you have at the particular time. So, you know, I don't see a negative here at all.
Well, let me just chime in with a slight potential negative. I've heard non-radiologist physicians saying, well, wait a minute. We do kind of all this stuff anyway. You know, we have a huge amount of administrative work, which is non-reimbursed. Why are you making such a big deal out of this?
I think one thing for the field of radiology, I think this counteracts some of the notions that, number one, we don't just sit in the reading room and read films. So that is one way to show our level of engagement with the other members of the hospital. The other piece of the equation is they can see exactly we are out there on the front lines doing different things. And then the third thing is actually we're actually quantifying it. I certainly know in our hospital, no other specialty group, while they may say that they're involved and they're doing this, when asked to prove it in a way such as this, they're unable to do it. And I think that puts our radiology group in a unique position that this is now part of our culture. And the other piece that I would say is we've demonstrated involvement by all of our radiologists. And I'm not sure if the other specialties can make that claim in a presentable, quantifiable format.
Great. A different question, which I think you partially addressed, but who's paying for this non-RVU work RVU activity, especially the quality initiatives?
So many of those things, again, we get some payment from our individual hospitals for medical directorship fees, include that our projects and things that we do. We get other forms of payment, such as if we're doing activities related to the CMS PQRS initiatives, we're getting outside national dollars from that. And so, and then the other thing, there's a lot of activities actually that, to be frank, people are just doing these activities. And previously they were doing them but not really documenting them, and now they're documenting them. And when you aggregate the data, it actually helps each individual radiologist in each of the different locations that they provide service. They can go to bat and say, look, we are doing these things as a group. And so some of it is compensated, some of it is not compensated. The goal is not to get everything compensated for, but the goal is to basically show all the value that's being provided.
Great. Another question. Does your group's compensation model incentivize radiologist participation in non-clinical value-added activity using the metrics you describe?
So currently at this point, again, 2013 was our baseline data. Our group is not engaged into a discussion with regards to whether some members should be paid more or some members should be paid less. And I think in talking with several members from other groups across the country, there's various different models. And I think the real key is, well, certainly payments can be made to individuals that maybe produce a lot more. We sort of take the approach that everyone should have equal opportunity, and it's a responsibility of everyone to provide some degree of value. However, that being said, if individuals want to participate in certain value activities, such as leadership training programs, which we consider a big value, our group does provide additional stipends for individuals that want to undergo certain numbers of leadership training or want to undergo, go to a leadership conference. So we are kind of have a hybrid model, but right now compensation is not based, but I do know of some groups that actually do it.
A related question in a way, in your practice, who collects, calculates, and organizes all of this data? I think that's a key question.
Okay, so as the individual sheets are filled out, they're sent to our, we have an administrative person who oversees the value management program data entry. They enter this data into a Microsoft Excel spreadsheet, and then me as the value management program director every month, I get a report of all the activities from each of the locations. And then then once I see it every month, what we're starting to do now is parse out each individual location, and the administrative secretary will send each individual location's activities to the chair of that department in a reportable format. But we started out as a very manual process, but we are looking with the development of a smartphone app to make this a lot more easier process. But again, we're still really relatively new into this. But again, we just have one administrative person that collates the data, and I as the director review it monthly, and then we put it into a central database, which really does not take a lot of time, into a database program, and we mine the data at the end of a year.
So a couple of quick follow-ons. Who pays for the administrator, and how much of your time is spent in organizing this? And really what I'm trying to get at is if someone took the charge and a lead in their practice, how much of their time do you think they need to spend on this?
So this has evolved actually very quickly over the last year and a half. So the administrative person in our group, actually we have our own billing office and our own billing personnel, so we've added this degree of responsibility onto the work activities of an existing executive coordinator. So it did not mean hiring somebody else. The other thing as far as my personal time now, compared to setting up the program, which actually now I've learned a lot, is groups can start out pretty small. So a director of a program maybe would need to spend maybe just a couple hours a month just monitoring it, and the initial setup process would literally probably could be set up in a day or so with an administrative secretary. I've laid out the template. It's a very simple spreadsheet, and it can start out easily, such as just documenting the number of committees, the number of conferences, and the number of meetings. And then as groups get more sophisticated or as they get more familiar, they can start adding more activities. But it really now, I probably spend, probably less than 5 hours a month just reviewing all the data, and it's probably more on the hours on the order of probably 2 to 3 hours.
Well, that's pretty amazing considering what you've been doing. And a sort of another question related is the spread and the range. And I know you showed that bar chart of the range. And what's the maximum amount of time you showed someone there who spent on these value-added activities? Maybe that was you, I don't know, but you don't need to unblind yourself. But you showed someone who's hardly doing any versus someone who's doing quite a lot. What's the max amount of time for the most productive, if you will?
Yeah, and so some of this is related to some people are going to be involved in more activities just based on their position, such as chair of a group, chair of a department, chair of a committee. There's going to be a lot more investment in time. Other activities also would incur a lot of time, and it's not necessarily during the working hours. So it's that if somebody is writing an article for a publication or something, they're spending a lot of hours writing that particular publication. And so again, this was just the initial snapshot. So the goal is not to have everyone equal, because certain positions will allow participation in more activities than others. But the key is the more different types of activities, the more types of participation you will get. The other thing is when somebody fills out an activity, they're essentially attesting to that. So this is by no means complete because there's probably a lot of activities that are done that people have just not completed the appropriate paperwork. But we're hoping that the app will take care of that.
So what about resistance from your staff? I mean, you're reporting these different activities, and you've showed us. And frankly, some of the people who are least productive in the value-added activities are not the most productive on the wRVUs. So what about resistance from the staff buying into all of this?
Well, I think the one key is we have now, and actually last year was the beginning of this year, was the first year we actually showed this data to group members. And we actually had the names attached to everybody, to each individual bar, so everyone could see where all the other members in the group were. And so that was a very early part of this year. And I will tell you, during the first 6 months of this year, compared to the first 6 months of last year, there's been an uptick of approximately 18% of value-added hours submitted by the entire group, such that the average has gone significantly up. And most of the people now, everybody has had, to some degree, an uptick from last year. But again, it's a cultural change, and even a year's time would probably still be considered relatively short.
Yeah. We've got about 3 minutes, and I'm trying to get the last few questions in here. And again, this is related to what you've just been talking about. The question comes is, at least in this person's experience, the volume of radiology isn't really going down. So how do you shift your time towards the value-added activities when you've got to keep the productivity up on the traditional wRVUs?
I think there's several things we've done as far as, and this is where sort of my background in lean healthcare is, we've been able to implement some changes related to reporting and structured reporting. So we have now started doing structured reporting templates where the technologist of certain modalities actually starts the report for the radiologist, includes in there the technique, includes in there the history, includes in there the type and amount of contrast. And so this markedly actually reduces our dictation time for some of these studies. So automatic structured reporting, automatic speech recognition through utilization of structured reporting templates is now really, we found, actually saves a lot of time by not having to dictate studies in the traditional sense that we've done. And dictation is the biggest part of our work. So that, I would say, has probably been the most beneficial.
Okay. So just before I wrap it up, I think it's a little bit unfair for you to exactly answer this question, asking about your exact RVUs in your practice, but presumably you've benchmarked your RVU productivity across the range of your radiologists, and I'm making an assumption here that the overall productivity of your department is fairly similar to other private practice departments. I think what this person is alluding to is maybe you're underproductive compared to other practices, so it's all very well you can do this stuff. But I suspect you're as busy as anyone else.
Correct, and I think the key thing that I don't have in here is the amount of time, so taking into account the amount of vacation and everything.
Right. So I'm going to wrap this up, except really a question for the host organizers here. A number of people have asked whether these lectures will be, this deck will be available offline for review, and maybe that can be sent as an email to the participants. So I really want to thank you so much for spending your evening and late afternoon with this session. I think these are just the sort of discussions we need to be having amongst ourselves, our groups, and our organizations. This is really central and core to what Imaging 3.0 is all about as we try and address these fundamental shifts and changes in healthcare and its delivery. So with that, I would like to thank the ACR for organizing this meeting, for everyone who attended, and I wish you well and have a good evening. Thank you.
Thank you.